Good day. I am Dr. Palugo Naboeze, and I will quickly be revising for the purpose of those who want a little bit of explanation on this BLS course. But for clarity's sake, I must emphasize that for the purpose of this course, I'll be using as a template the manual produced by the Dr. Disque Foundation. So compliments to the Disque Foundation for this offer for BLS course, as well as several other first aid courses, the CLS, PALS, first aid CPR and AED, and a few others. But for this discussion, we're hammering on the basic life support. Um, so we appreciate the Save a Life initiative as well as associated sponsors. I'll be adding a few other things for clarity's sake, as well as a bit to fine-tune it to what's obtainable in low and middle income countries. But before I start using the manual as suspected, you should have gone through it. So this is more like a brief talk to just explain some of the vital aspects as contained in this BLS manual by Dr. Carl Dix. Um, I would like to use to provide a more encompassing definition. In general, first aid I would describe personally as the first immediate skilled treatment and or assistance given to a sick, a suffering or an injured person before the arrival of a doctor, a nurse, other medical personnel, an ambulance, or before taking the casualty to the hospital. The definition to a large extent is self-explanatory. That is a skill, because sometimes help can come and then the help will be in error, which can end up worsening the condition of the casualty. Of course, the casualty is anyone who is sick, suffering, and injured and is being attended to. The emergency scenario, especially by a non-medical personnel, when the person is, of course, booked under a patient and is being managed in a healthcare facility, the same person can be referred to as a patient. So it's just more terminology based on the level of care who's rendering the care. A few other definitions will differ to other courses. So I will quickly start on the basic life support. As explained, the basic life support has to do with the first thing, active intervention that one should do for someone who developed a heart attack. What should be done to save the person? Like we know here, for the aspect of the concepts talking about the review by the heart's morbidity can be a bit on the high side, both in Western countries as well as in low and middle income countries. So heart attack can be a very significant cause of death world over. So talking about the basic life support and the talking about you can't talk well about basic life support without talking about the chain of survival. But first we're talking about the adult chain of survival briefly, and then the pediatric chain of survival. Ordinarily, we should appreciate that pediatrics has to do with someone below the age of 18, but for the purpose of BLS, many a time it is specified, especially when referring to people below the age of 8 years. Above that, as from puberty to adulthood, many a time the intervention is similar, except when specified, maybe with little alterations. So for the adult chain of survival, the initial step, as explained vividly in this text, is to recognize the sign and symptom as well as activate emergency medical service. Well, in most of these low and middle income countries, may not have a functioning emergency medical service, so activating EMS may just pass for calling for help from passers-by, from neighbors, other persons that can help in either transporting the person to a hospital or making the person to reach someone that will be able to offer some help. Like we know, sometimes first aid can actually be the definitive treatment for a condition, but many times the person might still need to be reviewed by a specialist, and that's why we say it's a treatment and or assistance. But whichever way, counseling the person while doing first aid, keeping the person company if need be, and a few other soft skills that should be assisted with first aid, we count more for assistance. So even if you're going to be rendering stepping to stop bleeding, for example, you shouldn't do that with a load of insult on the person. So assistance go beyond physical, we have the social aspect of it and what have you. So many times first aid is basically on palliative treatment. So most times it's not a curative or a definitive treatment, but a few times you do it and that's all. Other times you have to also counsel the person to be reviewed. The next for the other children to have is to perform early cardiopulmonary resuscitation (CPRO), and then talk about the defibrillate with the automated external defibrillator, or if you have a manual defibrillator and you know how to use it, you also want to use that. And then talking about the advanced life support, and then the post cardiac address care. Talk about referring to specialists. For the pediatrics, because pediatrics cardiac issues usually are not cardiac in origin, they are more of respiratory causes. So the first step is to prevent the arrest by making sure you take care of whatever it is that's going to cause the cardiac arrest, which very often are notice of respiratory origin, has to do with the lungs, the airway, and of course the tracheobronchial tree. The next step will be to perform early CPRO, cardiopulmonary resuscitation, and then the third, activate emergency medical service, as we explained earlier, actually in this part of the world. Then the advanced life support, then post cardiac care. For the guideline changes, usually based on International Liaison Committee on Resuscitation, is usually reviewed every 5 years. So in the previous decade, we have from 2000 to 2005, and then 2010, and then 2015. Should have one is 2020. So the major thing that you should take note of is talking about the rate. The rate is to aim at 100 to 120 compressions per minute. Doesn't mean you should give compressions all along, so we'll explain that later. If it's less than 100, you will not achieve enough that should, to a large extent, may make the maximum normal for the heart rate, which is 60 to 100. And if it's more than 120 and too fast, that you will not give time for the heart to refill, and so that will also count as being ineffective. The depth, it should be about 2 to 2.4 inches for adults, which is about 5 to 6 centimeters, and for children, just make use of 1/3 of the depth of their chest, which many a time pass for 5 centimeters or 2 inches. You should be careful not to make it too much, you don't cause some internal injury or fracture of related bones. And of course, the technique you have to practice very well, so you will not be too slow and not be too fast. As expected, you should not be performing CPRO over the abdomen, damage. You should not be performing them on the ribs, cause damage. You should not perform them on the tip of the sternum, that's the bottom, because its thought process is thin and can easily break and cause some other issues, fracture. So it should be at the level sternum, a little bit to the left, but it should be firm. And of course, there's an approach as explained in the manual. You can work your fingers. The sequence, usually it was airway, breathing, and compression, but now compression should start to the carb, CAB, compression, then airway, then breathing. Of course, should you really see that someone is choking, for example, you won't confuse that for this when you're talking about cardiac arrest. When you know it's cardiac arrest, it's carb. You don't confuse it from doing normal primary survey, which usually we want to clear the air first. And then the community approach, tell you about training others to know how to do so. The ratio is 30 compressions to 2 rescue breaths. So you are doing 30 compressions followed by 2 rescue breaths for adults. If you do it well, at the end of 2 minutes, you should have done 5 seconds. So at the end of 1 minute, you should have completed the 100th to the 120th compression. But of course, not at once. For every 30 compression, you break it in 30s, followed by 2 rescue breaths. For children, um, so if you also do it if you are the only person rendering the aid, 30 compressions to 2 rescue breaths. Same with infant. But should you have a second responder with you, then you will switch to 15 compressions and 2 rescue breaths. So high quality CPRO compression should be minimum of 100, of course, but not more than 120 compressions per minute. You should do the appropriate ratio of 30 to 2 to all ages, 15 to 2 if you are more than one rescuer. For children and infants, you should be able to switch rows after every 5 seconds to avoid the ineffectiveness associated with fatigue on the part of the rescuer. You should allow the chest to recoil completely, of course. You don't need to take your hands off the chest, so you shouldn't be leaning on the person. Do it in the appropriate position, minimize it undue interruption, so you should be able to start the process within 5 to 10 seconds after detecting that the person will likely have a cardiac arrest. And do not overventilate, that is own issues. Hyperinflation has a problem. And then you should work as a team when possible, with necessary feedback and maybe review post resuscitation. Um, so one of the things I also want to highlight is about assessing the casualty. Usually you say you check for the pulse. We are usually used to the unarrhythmic pulse, but for ease, for people greater than the age of 8 years, it's best you check the pulse at the carotid or the femoral. Carotid is just at the edge angle of the neck, angle between the neck and the flat, the dorsal end of the manubrium, the dorsal end of the jaws, and then the femoral, just at the groin, the crease between the thighs and the end, let's say the end of the abdomen. So I'm trying to use the colloquial word so everybody can follow. And then for infants less than 1 year of age, and for even those children from 1 year to 8 years, which you see fall under pediatrics for the purpose of BLS, we use the brachial artery, which is at the medial aspect of the arm, medial aspect of the arm. For yours as an adult, you won't feel it, so except for certain conditions. Then the airway opening maneuver, of course, very important. Simple airway opening maneuver. The idea is to make as much as possible a straight line between the nostrils and the lungs, like we have when we do early in the morning. Just stretch and try, extend your neck to the back. That's what the brain is actually trying to do, especially in industrialized area where we want to catch the morning air, which should be fresh because of the break, the overnight break. So it's colloquially named the sniffing the morning air position. So you're trying to attain that. To do that, two basic way to do that. For persons who you do not suspect an injury to the neck or the skull, so there's no fracture, so you do not suspect it, there's suspicion, you shouldn't use this method. You use what they call the chin lift. The person lying down is in the manner, and then the head tilt maneuver. For someone who you suspect cervical spine injury or a fracture, you do the jaw thrust where on the head side of the person, you just open the mouth and you be able to make sure the airway is patent. So it's also determined for one rescuer and two rescuer, which you should be able to read and know. One rescuer process are there. Two rescuers, usually what we change is first of all the switching of roles after every 5 cycles of CPRO. And the cycle comprises compression and rescue breath. So then the other difference is for two rescuers, for bound should have started the compression and get the aid. For children, of course, you would have started. If you did not witness the arrest, you should have started your CPRO for at least 2 minutes, that's about 5 seconds, before you even think to go and activate the emergency service. You have a number to call or go get AED. But there are two rescuers. While you are doing that, the other person can get busy and doing the other things that are also important. If you're unwilling, untrained, or unable to perform um, rescue breath with your mouth-to-mouth respiration, you want to use a mouth-to-mouth respiration, especially for adults, even for children. You also want to use a self-inflating um, ventilation bag or baby bag, locally called the angle bag, um, for children and for infants, especially small children and small infants, but more especially for infants. You want to make use of your mouth, the mouth and nose. Say the infant is big, and for the compression, while you're using two hands for adults, you can use one hand for children, or two hands if they are big, or if you're relatively small at the rescue. And for infant, make it of two fingers. If you are alone, two fingers of the one hand. And if you have an associate second member assisting with the CPRO, then, and if your hands are big enough, you can round the infant's chest, so you'll be applying the pressure with both thumb of yours. And so you can see the review questions there. You can just play on them. The use of a defibrillator. This has made controlled shock application very easy. It's automated, so it's largely foolproof, so anybody can make use of it with the instruction written. So just as a way of notes, for adults, the first part should be the right chest, the second part should be below, just around the mid axillary line, just the left mid axillary line, so it's kind of below the left armpit. You should make sure that the terminals are plugged properly. You should allow the AED analyze it while you sit in your CPRO, and should it encourage you to shock, then you press on the shock button. If you say don't shock, do not administer the shock. Continue with your CPRO. For children, the idea is do not make the two stuff breach on themselves, the pads. So one will be on the center of the chest, the other will be at the back. You apply, of course, if the person is wet, you should clean the person well and do not apply. If the person is already on oxygen, you cannot apply. Fire, electricity, and oxygen not compatible, flammable. Start burning from the person can even affect you. Remember the rule of first aid to prevent injury from worsening. So also, if there are signs, asking symbols that you cannot do that there, so you cannot go and using AED in a place that's already saturated with fumes from petrol products, or from a place where you have a gas plant and it's already leaking out. You don't want to do that. So that's why you should make use of senses, five senses. So if you are going to apply and you know that suspect the gas leakage, you better transport the person to a safer place, and transportation is a discussion of its own. Then, so the sequence is ready. So bring it out from the back. Place the person on the flat surface. The person should not be on water. The person is on snow, no problem. Apply the patch appropriately. If the person has a subdermal patch or other implants or pacemakers, you should make sure the pad is not over the pacemaker. It should be any other place, not over the pacemaker. Understand? If the person is on snow, you can defibrillate on snow. Once you've connected the pads as appropriate, make sure it's well connected and stuff. This is being analyzed. Your CPR is still on, and then once it advises a shock, you clear the individual, so you stay clear so you don't get electrocuted in the process. And once you administer the shock, you resume CPR immediately until the person becomes better or until advanced head arrives. And so that's that for it's quite easy. So for infants, I think I've explained most of the things along the line. There's really not too much. The rest are what we can easily get from the stuff. So the airway management, if you want to do the advanced airway, once it's on, you want to make it to give breaths, do not over 1 second for 6 to 8 seconds. Of course, if you are giving the breath, you should breathe in and blow steady into the person's lungs where the mouth or mouth can get movement, and the chest should rise. Breathing in is active process, so the person needs your help to breathe in, but breathing out is a passive process. So you blow in, body takes care of that by itself. Inhaled air contains very oxygen. Air contains about 21% of oxygen and 0.04% of carbon dioxide, but exhaled air contains some 16 to 17% of oxygen and about 4% of carbon dioxide. So the exhaled air contains enough oxygen that will be enough for the body of the person who has the bodies to use. So that's why you can make use of your exhaled air before you have other means to get oxygen. So what do we breathe in? Air. What do we breathe out? Air. What we breathe in, the body makes use of the oxygen part, and then the body from metabolism adds to the carbon dioxide fraction, so it increases during exhalation. And of course, when you are doing the stuff for the adult, you pinch the soft part of the nose, the mouth to mouth. There's also a mouth to stomach respiration, which we will not be discussing here. Then for the children, use your mouth to wrap, make it tight seal around the mouth and nose. And for the arm, if you want to make use of the arm back, let's make sure you form the sit so you should be in the right position for the child. For the children, you don't make sure you don't overextend the neck. Make sure you don't press under just under the chin for long or too much pressure, because that may also block the airway. Choking. So if you want to talk about choking, when it's something which can even be something on the body like saliva or outside like food materials blocks the airway, it can be mild, impaired, person can breathe, having some wheeze, can coughing, and we encourage the person to cough, and then you might need to apply 5 back blows with the ease of your hand in between the person's shoulder blades at the back, while the person is leaning forward. If it's severe and the person is showing the universal sign of crunching to the neck, usually with the both hands, except the person will have the one hand or both, or the person will cough or very big cough, the person is breathing or not breathing, very little breathing, is unable to make a noise or anything, or will become bluish, cyanotic, you use the Heimlich maneuver. For adults, it's described the person is labeled the umbilicus, and you do an inward upward thrust, the person in front of you, back to the person's back to your chest. Do that. It's forming something like take it from the level of the navel in towards yourself, then upward. For children, you do that on the person's chest. And then for infants, the infant will be lying your hand facing up and just do the chest thrust, just with the 2 fingers. You stand facing up with the head, it pointing downwards. The picture is there. So that's that. So in my case, for children, for infants, the infant will be facing down, the head pointing downwards at some angle, and then you give the back slap. Of course, don't be too hard with it so you don't cause more damage. So that is that for that. Good luck with your learning. Thank you.